So hello everyone. So thank you very much for coming to this TNT session entitled More Possibility in TEER, Treatment of Degenerative Mitral Regurgitation, sponsored by Airbus Life Science. I'm Kentaro Hashira, University Cardiologist, Tokyo, Japan. We also have my co-chair, Dr. Didier Chiche from Toulouse, France. And we also have the distinguished discussants Yuki Izumi and KKO. And the objectives of this sessions are to understand how a novel TEER device provides more possibilities in TEER for DMR, and to develop understanding of predictable and durable treatment of mitral regurgitation, to review the clinical evidence strategy and become acquainted with the most current data available so far. So please be very interactive. Please do not hesitate to ask any question you have. All the questions are welcome. We will try our best to address your questions. So first of all, I would like to introduce the first speaker, Dr. Shingo Sakata, who is my fellow from Keirin City Hospital. He's going to present a case example, creating your strategy for DMR with TEER. So Shingo, please.
It is a great honor to be able to speak to you today. I would like to present a case in which the Pascal system was effective in controlling degenerative mitral regurgitation associated with structural changes like Barrow's disease. We here report the case of an 83-year-old man. This patient has been under follow-up for asymptomatic severe MR. However, due to worsening heart failure, we decided to proceed with treatment for MR. Transthoracic echocardiography revealed severe MR, TEER, and PR. Left ventricular enlargement was not observed. However, both left and right ventricular dysfunction was observed. On 3D TEE view, the P2 segment appeared narrow, and a broad regurgitant jet, including the bilateral indentation jets, was observed mainly between A2 and P2. Pronounced PC prolapse was also noted. The measured values are as shown. This is a 3D MPR view at the middle of A2P2. A broad regurgitant jet due to A2P2 blowing was observed. Focusing on the indentations, significant regurgitation was observed from the bilateral indentations of P2. Based on these findings, the regurgitation between A2 and P2 was considered to be the primary region. Significant regurgitation due to prolapse of P3 was also observed at the A3-P3 segment. Prolapse of the PC was noticeable. However, little regurgitation was observed from that region. Here is a summary of the case. This patient had severe degenerative MR due to blowing of both leaflets and regurgitation from the bilateral indentations. The primary region was considered to be the regurgitation between A2 and P2, while significant regurgitation caused by A3-P3 was also observed and regarded as a secondary region. The P2 segment was narrow and no annular enlargement was not observed. The MVA was sufficiently large. How would you approach the treatment for this case?
Okay, thank you very much, Shingo. So 83 years old male who received the bypass surgery and every function a little bit reduced and a very wide jet from ATP2 and PCR as well, and the MVA is 5 and puncture height is 31. So maybe I can briefly ask the Yuki, so what is your treatment strategy for this case?
Yes, thank you. This is a very complex mitral valve. So the main reason is, as he's shown, the A2P2 bireflex prolapse and the billowing or prolapse, and this region is severe. But also A3P3 billowing or mild. And I'm concerned about the PC prolapse, but was the regurgitation from there only mild? Okay, Sakata.
Yeah, okay, perfect. So it tells us the case has really complex anatomy. So please keep in mind that we're gonna ask some lecturers, and finally the Shingo will come again and demonstrate how we treated this case. So we also have the distinguished speaker, Dr. Firas Zar and Dr. Tobias Geisler, Dr. Shunsuke Kubo, and Dr. Makoto Amaki. All of us are on the podium, so let's discuss together. And, okay, no. Yeah. So I would like to, so sorry for Firas. I'd like to introduce Dr. Firas for the first talk. So he's going to talk about the 2-year data of the Class 2D randomized control trial. Thank you, Firas, for coming over to Tokyo.
Oh, thank you. Thank you for having me, Taro. It's an honor and privilege to be with you all. And while we're waiting for what happened in that complex case that you show, I thought that I will share with you the Class 2D randomized trial and registry results. We recently presented the 2-year results of Class 2D. This is my disclosure slides. You know, the trial included the Pascal system, which, as we know, comes in 2 different implants, you know, the Pascal and the ACE device. Both of them have similar features in terms of how they clasp the leaflet, as well as a nitinol frame that when it closes, provides gentle tension on the leaflet, and also having the elongation feature that will elongate the device to get out of the subvalvular apparatus and trying to achieve the optimal position of the implant. This is the design of the trial. It included patients with severe symptomatic degenerative mitral regurgitation. The MR has to be 3+ or 4 for the patient to qualify. The patients have to be deemed suitable for TEER by the heart team. And then those who are straightforward anatomy get randomized 1-to-1 to receive the Pascal device, or 2-to-1 to receive the Pascal device, or the MitraClip device that was approved in the United States. And those who have complex anatomy were followed in the registry, and all of those patients have received the Pascal device. The primary endpoint was a 6-month endpoint, which, based on achieving that point, the device was approved in the United States. However, the secondary endpoints include effectiveness up to 5 years, and today we're presenting the 2 years outcome. It was 57 enrolling sites across the globe, and the patients who were included are those who have severe symptomatic degenerative mitral regurgitation. And again, the anatomical exclusion criteria, as you see on the bottom of the slides, is actually what determined those patients who were enrolled in the registry. And those who were enrolled in the registry, all of them received the Pascal system, whether it's Pascal or ACE. So what did the 2 years outcome look like? As you expect, it is a high surgical risk patients. So patients were older with multiple comorbidities, frail, kidney dysfunction. The EF was relatively preserved, which is what you expect from a degenerative trial. And the patients were quite symptomatic, with frequently had a prior heart failure hospitalization. 300 patients were enrolled, randomized 2-to-1, 2 receiving Pascal, 1 receiving the control device, which in this case was a MitraClip, and those were followed up to 2 years. Now, if we look at the MR reduction, which is what we all look at after we do a TEER procedure, you will see that over 90% of patients in both cohorts have MR 2+ or less. However, if we hone it down to MR of 1+ or less, which what we all consider the ultimate results after M-TEER, with more studies coming out saying that MR 1+ or less is key in achieving success after M-TEER, you'll see that result was achieved in almost 79% of the Pascal arm, slightly lower but not statistically significant in the mitral clip arm at 68.5%. But also it is important to notice that if we look at the 30-day data and the 6-month data, the 1-year data, and the 2-year data, the results of MR reductions are sustainable. And there is very few patients who have recurrent mitral regurgitation after the initial procedure. Now, if we look at the valve area in terms of hemodynamics, the hemodynamics after M-TEER was excellent, with the majority of the patients enjoy low gradient across their mitral valve in both the Pascal and the mitral clip. And this actually translated in favorable outcomes. If we look at the LV remodeling by the core lab, there is significant improvement, as well as functional and quality of life outcome. There is significant improvement in those outcomes in both the mitral clip and the Pascal arm. And this translated into very low mortality, up to 2 years, as well as low cardiovascular mortality, freedom from heart failure hospitalization, and freedom from mitral valve reintervention, indicating the low adverse events after up to 2 years. Now, if we shift gear and we talk about the registry, and again, the registry is a more complicated anatomy, sicker patients. A lot of them have multiple jet, MAC, small valve areas, MR pathology that is not coming from A2P2, but coming from the commissure. So really complex anatomy. And all those patients have been treated with the Pascal system. And you'll see that the degree of MR reduction to 2+ or less is over 90%. The 1+ or less is also high. It is not as high as the randomized arm, but is shockingly high for how complex the anatomy is to be able to achieve, over 68% of MR reduction, 1+ or less. And this is true if you do the paired analysis as well as the unpaired analysis. And also the valve area and the hemodynamics of the residual opening of the mitral valve was favorable. And all of us struggle in appreciating how much MR we have after TEER, if there is MAC or a complex anatomy. So this is an indicator that even if we misjudge the residual MR by echo, the favorable outcome on LV remodeling indicate that the reduction in mitral regurgitation is real. And so is the improvement in functional class and quality of life outcome for those patients up to 2 years. And this, again, translated with low mortality, cardiovascular mortality, as well as freedom from heart failure hospitalization and valve intervention. So to conclude, this is the longest follow-up of the only prospective core lab adjudicated, CEC adjudicated adverse event evaluating 2 contemporary M-TEER devices, the mitral clip and Pascal. The 2 years results from the Class 2D randomized reinforce M-TEER as a very valuable treatment for patients with severe symptomatic degenerative mitral regurgitation with a favorable survival, robust and sustained MR reduction, significant and durable ventricular remodeling, and improvement in quality of life metrics. Thank you very much.
So thank you very much, Firas, for your fantastic lecture. And Class 2D study demonstrated very robust data demonstrating the significant and sustainable reduction of MR throughout 2-year follow-up. I think it's quite robust data. And maybe I would like to ask Shunsuke, so how would you like to utilize this data? How this data impacts your daily practice in our country?
Thank you for the great data. So I think my especially impressed about the sustained MR reduction in the Pascal group. So as you can see, from the I think the 1 month to 1 year and 2 years follow-up. So I think MR grade much sustained in the Pascal group. So I don't know the exact reason about the reason of the difference between these two devices, but this is so impressive for me. Yes. So do you have some comment about this difference?
Yeah, I mean, I think it is, well, it is important to recognize that the difference in this study was not statistically significant. However, what we experience in our clinical practice is, once we deploy the Pascal device, when it's released, there is no increase in MR after release, and this result is sustainable. We've shown in this study up to 2 years. Now, it's also important to recognize that early in the study, there was a lot of most of the devices that were used were Pascal. The ACE device was not available. The ACE device was introduced later in the trial versus, the mitral clip most of the devices that were used were the G4. So I think in our contemporary practice, the majority of what we use for degenerative MR right now is, the ACE device. So I think that those subtle differences in between the two devices, as well as the incorporation of the nitral frame, has resulted in slight differences in the durability of the repair.
So thank you very much, so Shinsuke. So taking into account this data, how would you apply mitral TEER device in your daily practice?
Yeah, so I think that both this data and also the structure of the device, so especially in the nitral frame, flexible nitral frame, and also that we can do the elongated system. So firstly, this year, last year, we start to use the Pascal device, and actually we switched to the device from the mitral clip and the Pascal in the primary MR, and especially in the non-central region. So we can do the procedure without any risk of also the caudal entanglement and also the leaflet injury. So I think the procedure became a much more safe, and no stressful procedure.
We feel quite safe with Pascal. Yep. And Makoto, so we also presented the data yesterday on the Ocean Mitral Registry comparing two devices. Could you please comment on that, and could you compare our result with this the data that Firas demonstrated?
Yes, thank you. First of all, congratulations for this Class 2D trial, and it was really impactful. Obviously, we know that the mitral clip works really well in a DMR, and new device, Pascal, is comparable to these two mitral clip devices. Amazing data. Regards to the Ocean data, I presented yesterday that out of 3,700 data, we investigated the MVA divided into 3 groups, and we noticed that there's no statistical difference in outcome, even with a small MVA, and that was really interesting data that came out. And it was interesting to see the data from Class 2D that the difference between the mitral clip and the Pascal didn't have a strong impact on the mean pressure gradient, because the device difference between the Pascal and mitral clip, Pascal is more passive towards the valve, and I was expecting better mean gradient in the Pascal group, but in the data it was not. Do you have a data on the small MVA size data that has been shown the difference between the two?
Mm-hmm. Yeah, I think so this is a very good point. The patients who have small MVA were enrolled in the registry, and those patients were all treated with the Pascal system. And those patients enjoy low gradient across, the mitral valve. So there was no functional mitral stenosis even in the patients who have a small valve area. Now, those patients were not randomized, so it's hard to know how Pascal did compare with the MitraClip. But you're right, in the patient who have larger valves, there was no statistical significance in the residual mean gradient after either Pascal or MitraClip.
I think that's quite important to know the difference between Western cohort and our Asian cohort, because our Asian cohort has really small anatomy compared to that of Western people. So we need to tailor-made our clinical practice to our own cohort. So KK, so you studied the Pascal program as well. What is your initial impression of this device?
I think the main main takeaway I had was that with the Class 2D data that, this is a safe, efficacious technology in a randomized controlled setting. So I was confident to use it. My initial experience was a good one. We had very good results. I think as an operator in this area, the key thing is for us to understand the nuances of each technology, when to use it. Kubo had given a good example of commissural disease where the ability to elongate is a valuable asset. So I think I'm still gaining experience. I want to know more about the technology so that I can tailor, the choice, the appropriate choice of the device so that we have the best outcomes for patients. So it's still on a bit of a learning curve, and I think the key thing is to know the nuances.
Yep, thank you so much. So first, thank you so much for your presentation. We really understand that the Class 2D is really robust data, and we really learned a lot from your data. And hopefully we can apply this data to our own Asian code. Thank you so much for your presentation.
Thank you for having me.
Okay, we're going to move forward after this beautiful lecture about the outcomes, the clinical outcomes that can be expected with that new technology. So let's move with you, Tobias, about the predictability to keep the result that we've achieved and to how sustainable it is and how can we predict what we see before the final release.
So thank you, Didier, for the introduction, and it's a real pleasure and honor to be here and to share my experience with the Pascal system. So we actually heard about it, and we have some robust data, I think, from a randomized trial. These are my potential conflicts of interest. So I come from a center that is based located in the south of Germany, in a university town called Tübingen, one of the oldest universities in Germany, ranging back to the 16th century, in a quite hilly region, the Swabian Alps. And this is our cath lab during a procedure of TEER. That's our setting, actually. We do quite a lot of TEER procedures. We started early in 2010 and started with a MitraClip system, and then just now almost completely shifted to the Pascal system. So we have been using the Pascal system since 2019 and are currently doing about 100 procedures annually with 42% of DMR cases and around 20% of complex patients. That is similar to what we have seen in the registry, the 2D registry. We are doing all our procedures under deep sedation. The patient outcome is very good with this approach, and we just recently published also our experience with the Pascal system in this approach with very good outcome results. And I think the Pascal system, due to its flexibility, is a very good option with this deep sedation approach. So I don't want to tell you more about the design. We actually heard about this, the flexibility, the 19-node design, the elongation feature, which is very helpful, I think, in complex anatomies. We have two versions, the Pascal ACE and the Pascal implant or Pascal P10 with a broader profile. And I think the precision system, due to its responsiveness, has also made a big step forward. It reduced the procedure time at our center at about 20 minutes at mean, and it also makes the whole system more stable despite the flexibility of the system, which really helps to navigate also through complex pathologies. So I just want to add some real-world data to the randomized trial results, and I just presented the MyClass 2D study results. You can see also here that there's a sustained durability, and this is, of course, to do with the predictability. So the predictability, of course, has different dimensions. And of course, we want to predict a good outcome in our patients. And I think we can confirm this. As you can see here, we have similarity to the Class 2D study. We have a good outcome with regard to MR reduction, with more than 97% of patients not having more than 2+ in DMR patients. So this is only the DMR cohort in this MyClass 2D study, and this is accompanied by a good functional outcome, sustained functional outcome, and also a quality of life. So we trying to develop a kind of algorithm how to choose the right device. So we have two options, the Pascal P10 and the Pascal ACE. That's, of course, our individual approach, actually. These might be an algorithm, and of course, the real world sometimes different, more different. So we have combinations of pathologies. But this could be a pathway how to choose the initial strategy, actually. And that was developed within an expert group, within the Pascal focus group of European experts, and we currently investigating this approach, the effectiveness and safety in a prospective way. So I just want to highlight some of these scenarios. I think in a prolapse situation, the Pascal system, and historically, I would have treated this maybe with a broad and long device with a mitral clip XTW. I think this could be also an option. But here, I think the Pascal ACE, to its approximation force, was a very good option. This was a severe prolapse of the flail and a caudal rupture in the anterior leaflet. And we treated this patients, I think, quite well with two devices. And also here you can see that the elongation feature comes into play, and that allows us really to get quite close to the first device. And with this approach, I think we treated this severe MR quite well, from reducing it from MR4 to almost trace with a residual 3D error of only 0.01 square centimeter, which is a perfect, excellent as a result, I would say. Of course, we reduced the orifice area, and in this case, it was reduced to 3.5 square centimeters, and the gradient was 6 millimeters mercury. I think this is something we can expect in the DMR patient population. And we have some cumulative data now, for example, from the PRIME MR registry, that we can accept that a gradient of 6 to 7 is even acceptable. That's changed. Previously, there was a strict cutoff of 5 millimeters mercury, but I think 6, 7 is acceptable and not associated with an adverse outcome. And also, this registry shows us, we have similar data from the EXPAND registry, I think, that MR reduction is more important with regards to outcome improvement than the residual gradient, if it's in the range, as said, of 5 to 7. So another scenario, which I think is a good scenario for the Pascal ACE, is a commissural non-central pathology, as it was in this case here in the P1A1 region with an eccentric jet, also calcification of the annulus here. And here we need a very steerable device, flexible device, I think, which is the Pascal system, and also the elongation feature was quite helpful here. Usually here in perpendicular to the cooptation line, we try to achieve a clocking of 1 to 7 here. I think the multiplanar imaging is quite helpful also in this situation to adjust the angle in biplane, increase the angle here in this location. And I think with this approach, using the Pascal ACE device, we could achieve a good result. Another scenario is restrictive short leaflets. I think with this algorithm, with this stratification, we can actually predict a good outcome here. 2 cases, this was a short restrictive PML without calcification. And I think the Pascal P10 is a good option because due to its closing forces, with this restrictive PML, the Pascal doesn't close completely. It remains in a kind of V shape, and I think in this situation, the spacer, the larger spacer of the Pascal P10 is really good and helpful, and the lower approximation forces prevents that you lose actually the posterior leaflet, and that I think was a good solution here with a very substantial reduction of MR. And another issue is calcification, and this was a patient with a short restrictive PML with leaflet calcification, not only the annulus, but here you can see we tried first, of course, to spare the calcium, to put a Pascal P10 quite close to the calcium. This was not a good strategy. You can see here that the MR was still high. So we tried to do something what we normally not do, what is not recommended. We tried to grasp the calcium itself, as you can see here. And you can see, and the video runs quite long, that the calcium is almost squeezed by the clasp here. And I think this is an advantage of the location of on the orientation of the retention elements here, which is quite at the basis. So we can really safely, I think, grasp also this here, this calcium. This worked fine in this scenario, and also it was a durable result. So we saw this patients 3 months after, and the clip was still not detached, I can say, with an acceptable gradient. So I want to conclude. I think we have now data that we can predict a good outcome in our patients with using the Pascal. We have a robust and durable MR reduction, high survival and low rates of heart failure hospitalization, clinical meaningful improvement in functional status. So I think this increases really our confidence due to the predictability of procedural success. And this has already been mentioned that with the Pascal system, we see often an improvement of MR reduction after release of the system. And this has something to do with the passive closing forces here. And this is, for example, one case where you can see the MR before release was still about 1, but here you can see that it really reduced well after the release of the device. And that has also been confirmed systematically. We contributed to a registry here from our colleagues in Essen that was presented at the EuroPCR last year. And they systematically analyzed the MR before release and after release by error measurements. And you can see that a very low minority of patients, the MR deteriorated, but the majority of patients, 20%, improved, and in 80% of the patient, it remained unchanged. I think this is a very positive result, which I have to say I don't see with the mitral clip in that situation. Thank you for your attention.
Thank you very much, Tobias. Maybe you can join us, and then we'll have a bit of discussion. So it was a very nice description of what we can expect with that device and the fact that we can really anticipate the final outcomes, procedural outcomes for our patients. And that's really reassuring in contemporary practice to be able to achieve that. The first talk was about the sustainability of the outcomes at 2 years. You've shown more or less the same thing, following up your patients. I have a question for you both. I'm going to start with you, Tobias, about the learning curve. In your experience, how long does it take to become confident with the system and to be sure that you're going to achieve minor regurgitation, residual regurgitation? Does it take a long time and a large number of cases, or did you find it to be quite short?
So we had experience before with TEER, of course, but I guess, or I would say that when you start with TEER, I think the learning curve with the Pascal is very steep, I have to say, because of the responsiveness, and this has really improved with the precision system. And I think that's something also we saw in the ocean registry. I think this is a very early learning curve, and despite this early learning curve, we have such good results. I mean, that's really impressive, I think.
So that's a very important point. And was it the same in the US for in your experience, Firas?
Yeah, I mean, I think it's for most sites who use Pascals or sites that have used MitraClip for a long time. I mean, MitraClip was available in the U.S. for a decade, and it's a keyed system, and the Precision is a not keyed system. So there is a lot of the features of the Pascal Precision and the Pascal implants were very quickly adopted, and I would say that probably the learning curve in the U.S. for people who have used MitraClip before I totally agree with Tobias, was very quick, and it was 5 to 10 cases.
Okay, so that is a very important point, just because some centers may be kind of reluctant to switch or to integrate, even if it's not a full switch, but to integrate that new platform to better tailor some anatomies that we're going to describe afterwards, furthermore during the symposium. If we speak about the sustainability, predictability of the results, it has to do something with the number of devices, the number of implants that we put per patient. Is it predictable because you can put more Pascal and you get a stable gradient, or is it predictable because with one device, what you see is exactly what you're going to get? Could you answer that, Tobias?
So our average number of devices is about 1.4, I would say. We try to integrate our anticipation of the number device into our algorithm, and normally if we think we have to use 2 devices in this situation with multiple jets or broad jets, I think the initial strategy would be an ACE, I think. And with this, we can actually contribute to a quite low gradient. So the mean gradient in our patients, that might not be the case for the complex patients, about 3 to 4, and that really aligns with the registry results.
Same experience in Class 2D registry, 1.4 was the average?
Yeah, I mean, I think so one thing that, at least in the United States, for the Pascal sites happens simultaneously, which is the independent leaflet capture.
Yeah.
Because, G4 and Pascal kind of rolled around the same time in the US. So for a lot of centers, it was their first exposure to independent leaflet capture. And I think that feature has been tremendous for a lot of the Pascal users because of the system being softer. So you're more likely to be able to clasp one leaflet and move the device and clasp the other. So the ability to optimize and get leaflet capture was, in a way, was more quickly adopted for Pascal than it was in the MitraClip in the U.S., and that resulted in improved outcomes. So, for example, very few cases with Pascal, you put the first device and zip next to it. Because most of the time, if you have the leaflet, you can optimize the second leaflet with the independent leaflet capture, and it is relatively safer because the system is flexible.
And it's quite interesting because it's one of the elements that we always consider is the procedural time. Because when we do these procedures, we have a lot of patients to treat, and it's kind of important. And having the ability to optimize, to be able to potentially deal with that differential capture, to reassess, did you find out that this has increased the procedural time in your experience? Or roughly, is it the same? Did it remain the same as for the MitraClip? Yeah.
In the trial, despite the fact that the majority of the sites was their first exposure to Pascal, it was similar procedure time.
So let's move maybe more into details into the procedural aspects. Tobias, you were saying, okay, what I see is going to be what I'm going to get for the patient once I release the device. But there is something that is very important, is what we see immediately. The patient is under conscious sedation with a certain degree of anesthesia, and we see some regurgitation. Is it what we have to accept, or do you stress that result? Do you try to challenge that result? What do you do, if so, to make sure that you get mild regurgitation, and then once the patient is fully awake, that regurg is not going to increase? Is it important to stress and challenge the result?
Yeah, I think that's an important point, Didier. That's a critical look. I mean, we have this approach of deep sedation, and that affects, of course, the blood pressure. So we try to keep the blood pressure high in a kind of real-world situation, actually. And if the blood pressure is low, we certainly do a stress test with norepinephrine to get the blood pressure high, and also we look for the heart rate, actually, with regard to the gradient. So that's something we try to simulate in this procedure. I think this is a very important point, yeah.
Let me ask you something, Makoto. So we have the patient. I have witnessed in my experience a certain demand from the patients quite quickly after the procedure for a decrease in their medications. For this type of a DMR patient, you get a very nice procedural outcome. Do you continue the same therapy, the same treatment, or do you withdraw the diuretics, and at which time point?
Well, thank you very much. Yes. For DMR patient, you would think that the DMR is the only problem for the patient, and if the MR goes away, I think you would expect that you could reduce the medication. However, a lot of patients who comes in to do the TEER is old patient, and they do have a HFpEF aspect as well as the DMR problem. So I would stick on to the first medication for a couple weeks, and if the patient gets dehydrated or some rise in renal dysfunction, then I would reduce the diuretics and stuff.
You want to add something?
You're going to laugh at me, Didier, and call me old school, but that's all right. I still believe in hemodynamics, and, the Pascal system has a port for continuous LA pressure monitoring. I, routinely connect and, look at the MR, the point about the blood pressure and the dynamicity of the hemodynamics is true. And, if you see a significant drop in the LA pressure, that is reassuring, and that's what the patients feel.
Thank you. Yuki, I'd like to ask you something, because that talk was once again about the predictability of the outcomes. And one thing is the efficacy of the capture. We have grasped a lot of leaflets. We are happy. The second one is where we have been efficient at reducing the MR. The last one is the gradient. Have you observed the switch in terms of mean gradient that you get, moving from 1 Pascal and adding another one, or is it stable according to your practice?
Thank you so much. So mean gradient is the most important factor as assessing the mitral stenosis, but also 3D MVA is also important point. So it is something difficult to measure the 3D MVA in the procedure, but if the gradient over 5 or 6, we must measure the MVA. So the mitral transmitral flow is increasing in the volume overload or such reason. So also MVA is a key point of assessing MS. And also for reduction MR is its point very good important point is leaflet insertion. Also in Pascal is very important. So we record the clasp down and leaflet insertion every motion. And so also in the Pascal is a big large spacer with P10. So it is very effective for small MVA in the Asian patient. So this is the point, I think.
So quite stable gradients, and I like your idea of we are all learning, and it's about fine-tuning the way we assess these outcomes, and the MVA makes sense, definitely. And do you have a kind of cutoff for us?
Yes, 1.5.
So if we are less than 1.5, maybe we shouldn't put another device.
Yes, okay.
That makes sense. And maybe KK, one question for you, because it's for the audience, maybe some of them are not so familiar with the devices, the P10, the ACE, slightly different features. With the availability of the ACE, has it become your default system? Because there is a system that we have to start with. Tobias said ACE for the vast majority of the cases, and then P10 seems to be for these specific anatomies, or do you have a different strategy?
For the Pascal platform, I think our experience is very limited still, but it seems like the ACE platform seems to be a good start, workhorse for most pathologies. I'm curious as to what our collective experience will be with the P10 for atrial functional MR, which is an area which we are very anxious about. But I think, to answer your question, the ACE would be the go-to for baseline if I were to use a Pascal.
So that was a quite interesting discussion. I've been seeing the outcomes from the class 2 D registry, DMR patients. That was confirmed with your local experience, a huge expertise, so we can see that it's definitely sustained, and it's reassuring to see what we see immediately procedurally before the release is going to be maintained, and that's without the cost of a need for an additional Pascal or an increase in the mean gradient. So this is truly reassuring. So I think, Kentaro, maybe we can move forward. Yeah.
Perfect. Okay, so I would like to introduce the next speaker, Dr. Makoto Amaki, and he's going to present a case review on the small mitral valve area with a patient with DMR.
So this is a case review of a small MVA DMR, which is very common in Asian population. So I think a lot of doctors have experienced these cases. So this is my conflict of interest. So as you know, in the EXPAND G4 study, there are some subgroup that it has a risk of stenosis. It's about 5%, and the risk of stenosis includes the severe annular calcification, leafless calcification, MVA less than 3.5, but still they do have a significant reduction in MR, even though there are risk of stenosis. Well, what about the transmitral gradient after mitral TEER, and with that impact on the mortality? And this data shows that if the mean grade in the primary MR, in the moderate MR, and also the mild MR, if the gradient goes up above 5, they do worse prognosis comparison to the lower mean gradient. So let's go into the case. 88 years old male with a severe DMR, 3 months earlier admitted with acute decompensated heart failure and transferred to our hospital. Severe DMR was detected, and there were no conservative treatment options due to the high surgical risk. He was discharged home with a he was admitted to another hospital and discharged home firstly, and continuous inotrope infusion was done to this patient and transferred to our hospital after that. And he was expecting less invasive treatment. BNP was over 1,000, and creatinine was 26, and STS score was over 8. So it's a high surgical risk with a high frailty. Echo shows the preserved ejection fraction relatively, but MR was significantly severe, and the P2 prolapse was observed with a mean gradient of 8.5. Looking to the transesophageal echo, you can see the complex anatomy with the P2 and P3 segment and flail, and also the jet is coming from the lesion. PML length was relatively short, with 8 millimeter, with mitral annular calcification adjacent to the PML. And notably, the MVA was 3.4 centimeters squared. So there is a risk of stenosis. And also the lift was 17 millimeter. It's a wide flare. And this is another view of the 3D amphas and by commissibility. As you can see, there are some segment also from a PC segment. The jet is coming between P2 and P3 PC. Also, if you're looking from the left ventricle, there are some aspect of the regurgitant jet coming from P1, P2 indentation. So we selected the Pascal ACE, and since the lesion is medial side, we try to get as much height as possible for the septal puncture, and we could get 45 millimeter. And we tend to use MPR for these commissure lesion or non-central lesion. First, we dive into the P2 medial side and try to grasp the P2 segment, and as well as as expecting the P3 was also reduced. However, after the grasping, there are still MR jet coming from the lateral side of the P2 segment. Also, there's MR was coming from P3 lesion as well. So we thought that one clip or one device was not enough. So we switch into a two device therapy. So we select we move the device into the P3 lesion, and try to grasp the medial MR with the one device. We could grasp the P3 segment, and the P3 segment MR was reduced. And then we were worried about the mean gradient, but luckily the mean gradient remained 5.2. So then we move on to the second Pascal device and try to grasp the P2 on the center. We dive into the P2 segment, try to grasp the P2, and MR reduced to mild. And the mean gradient was 4.8. And after the 1 month, MR was traced, and the gradient was 5 to 7. So it was a really tough case, but we could remain low mean gradient even with a small MVA. So this case is a small MVA challenging situation for MTEER. Pre-MTEER MVA and indentation assessment is more important than the transmitral mean gradient, since high gradient can be obtained due to numerical factors, MR severity, tachycardia, and anemia. Pascal device might be the better solution for a small MVA patient. Thank you very much.
So thank you very much, Makoto, for your fantastic case presentation. And the small anatomy is quite relevant to our Asian cohort. It's quite an important burning issue in our region. So maybe I'd like to ask Yuki, so your opinion. So because sometimes in the patient with small anatomy, we need to decrease MR, but also we need to be careful of the increase of the pressure gradients. How would you prioritize two factors, and what is your most important factor for you to decide the endpoint of the procedure?
Yes, thank you. Many data shows that eliminate MR is the most important point, and then the mitral stenosis. But sometimes, in this case, the pre-mitral mean gradient 8.5. Wow, I maybe maybe I can't conduct mitral TEER. I'm doubt me, but happily, in this case, there is a deep indentation in P1, P2, P2, so allows P1 moving after the A to P2 clip Pascal. So very impressive case. Thank you so much.
Yeah.
Yeah, I would like to add that comment. Yeah, first we thought that same doubt that we might create MS, and this is not the case for MTEER. But as you said, the indentation is really deep, and we thought that Pascal might be able to be the good choice for this case.
So I think that it's great decision to proceed to mitral TEER, even though the patient had the increased pressure gradient before procedure. So Makoto, how would you stratify the patient if the patient can merit from mitral TEER before procedure, and how did you decide to go or not to go to the procedure?
Okay, as I said, the indentation is one of the factors that can get the iatrogenic MS, although the MVAs can be like, let's say more than around 4. Some case you would be able to have a mean gradient of 10 after one clip or 1 Pascal. So indentation first, and also the anatomical valve frailness, we call it. If the valve is thick and not able to open even with 1 clip, then I would say this might be the case for abortion. But the good thing about this device or MTEER is that if the mean gradient goes up, if the LA pressure goes up, then we could obviously come back without placing the device. So I think we would definitely go for it if there is a slight chance.
Yeah, the Pascal is quite flexible, and it usually doesn't increase the pressure gradient that much. And it's also quite easy to retrieve the device because we can elongate the device. Thank you very much for the pointing at a very important topic. So I have a question to KK. So we also have the very similar population of Asian cohort with small mitral valve area and body size area. So do you have any cutoff point to proceed or not to proceed to mitral TEER, or do you take into account the body size or the patient as well?
I think this would have to be an integrative approach, and also the expectation of the patient. If it's a 85-year-old, and maybe they will go down to just walk to the neighborhood store, maybe we don't need to worry too much about mitral stenosis. Although in the setting of rip-roaring mitral regurgitation, the patient cannot even get out of hospital. So it's a bit of an integrative approach. I take notes of the OCEAN data, which suggests that in a valve area of less than 3.5, we can do the procedure safely. So with new technologies like Pascal, I think it is particularly reassuring. So my approach is we have done cases of valve area less than 3.5, but I think the key thing for us is to see, what is the predominant problem for the patient. Sometimes the gradient can be contributed by the MR as well, and if the valve area on 3D is reassuring, it's maybe still more than 3, I would probably still go ahead. Less than 3, I would think very hard, and integrate the body size as well as expectation of the patient. If the patient says that I just want to go home and not stay in hospital, but I'm okay to be a bit breathless, but I want to go home, then we might still offer.
Okay, so less than 3.5 yellow signal,
Yeah.
and less than 3, maybe a red signal.
Yeah, I'm hoping that we can generate more data from this part of the world, OCEAN and other registries, to hopefully inform us what really is a threshold. Yeah.
Yep. So we have Shunsuke here with us, and you published the data from OCEAN that even with the small mitral valve area, so the mitral TEER is still doable. And could you please introduce your data again? And then, so could you please think about if the Pascal may change our criteria in the future or not?
Oh. It's a very difficult question for me. So actually, in our data, the OCEAN mitral data, a patient with a mitral valve area less than 3.5, so almost similar clinical outcome, including death and heart failure hospitalization, and also MR grade. But actually, the mean gradient are a little bit high. So post-procedure mean gravity a little bit higher in the patient with a smaller MVA group. So in the Pascal device, I think I impressed about the algorithm from Dr. Tobias. So I think he recommends the P10 device in the either MVA less than 4 square centimeter. So actually, I don't have enough experience about the P10 device for the small MVA, but I think big spacer may be more effective for the smaller MVA, and hopefully I think less than 3.0 will be will be a candidate for the TEER, because we don't have any device for the TMVR now, currently.
So now you're a leading physician in our country, so please let us know your experience later. And Tobias, you have huge experience with both P10 and Pascal device. So could you please recommend us how to treat a patient with small mitral valve area? And is it better to go with P10 first, or?
That's our usual approach, and I congratulate you to this elegant case, and it really shows that we can use 2 devices even in small mitral valve area, and also the Pascal ACE went well here. Maybe following our algorithm, this might have also been a case where we could have used the Pascal P10, because the jet was actually quite broad, and we had already a reduced mitral valve orifice area. And I think there we I think can take advantage of the broader device when we think it's a one device strategy, or we try to follow one device strategy, and also the spacer comes into play. And previously there was always the thinking that with a broader device you risk a higher gradient actually, but it's the opposite, I have to say, from my experience. And we had actually some cases where we tried to change the system procedural because of gradient issues. And I think actually the ACE, due to the approximation force, sometimes risks more higher gradients compared to the Pascal P10. Yeah.
That's great.
Could you question, Dr. Tobias? And in Asian patients, small MVA and also small mitral valve complex, so dense coda maybe.
Yeah.
So in this Amaki's case, maybe if medial side there is many coda from the PPM, posterior pulmonary muscle.
Yeah.
If we using the P10, how about the caudal entrapment or caudal?
Yeah, I can understand your fear, and that's also a strategy in a commissural non-central region. We prefer the ACE because of the navigation possibilities. Also, dense caudal structures are an issue here. But still, I mean, if we have problems with the orifice area, the Pascal is not exclusive. We can use the Pascal P10 here, and we can take use of the elongation features and the diamond shape feature here to get into the situation. So it's not exclusive. You can use it, but our preferred strategy, of course, is the Pascal ACE in these situations.
Thank you.
Yeah, that's a very important point and a very good question. And we can easily escape from the entrapment for the mitral coda with the Pascal system. So in this session, we really appreciate that the Pascal ACE or Pascal P10 provide us the new possibility and better treatment for the patient with a small anatomy. So thank you so much for your very nice talk, Makoto.
Okay, now, Shunsuke, if you want to guide us through cases of non-central DMR.
Thank you, Didier, and thank you for the opportunity to share my case, non-central DMR. But I think this is a typical, not so difficult case compared to the Makoto's case. So this is an 80 years old gentleman who have a history of the severe primary MR, Parkinson AFib, and the coronary disease. So after the PCI for left main coronary artery. So his SAS was relatively low, but we selected the TEER procedure due to his frailty. So the medication is, as you can see, optimal. And chest X-ray shows some lung congestion here. So ECG shows AFib. So this is TTE. So LV was a little bit dilated, but the LVEF was preserved with 55% of the LVEF. And the MR can be seen coming from the medial commissure region. And the EROA was 0.54, indicating a severe MR. And also he had also the pulmonary hypertension. And the MVA was 7.63, so indicating that we can do the multiple devices in this particular patient. So this is 3D TE. So you can see the bileaflet prolapse, both A3 and P3. But you can see some cord rupture here, so medial lateral P3 area. So this is 3D color. So 3D color is you can see the severe MR. And also this is a 3D image looking from the LV side. And when we look at the 3D image from LV side, so MR color are located in only the A3P3 region. So there is no MR outside of the A3P3. So this is a biplane image. So you can see the X-plane image. Over here is this is a lateral A3P3. It's difficult to visualize, but you can see the rupture code here, and very massive MR here. And also that we cut the medial A3P3 by the X-plane image. You can see the bileaflet prolapse here, and also that we can see the so much MR is a medial A3P3. So from these images, we have to cover the all part of the A3P3, from the commissure to the border to the P2 and P3.
Shunsuke,
Yeah.
Can you make just a pause, just to put everything into perspective? Firas, I'd like to ask you one thing. There was the randomized trial arm, and then there was the registry. This type of anatomy, would it be randomized or more a registry patient from the class 2D?
Yeah, so I think this will be considered a commissure leak, and that will automatically put it in the registry.
Thank you, because we are only seeing extremely challenging anatomies, and thank you for sharing these cases.
Yeah, thank you.
Please proceed.
Yes. So we have to plan the procedure using the Pascal device. So I think the 3D MPR images are very useful for both the planning and also the inter-procedure guidance. So this is a A3P3, and we plan to put the two devices, 2 Pascal S from the medial A3P3 and the lateral A3P3, and 11 to 5 o'clock perpendicularity. So based on my planning, so our echocardiographer made the very beautiful 3D MPR image. This is the first target of the medial A3P3. As you can see the red line here. Red line means red line actually the set like the first Pascal Ace. And we can see both the leaflet. So we can see both leaflet anterior and the posterior leaflet, which should be grasped using the first Pascal Ace. And the second target is here, so lateral A3P3. And the lateral A3P3 here, we can see the rupture cord and the flare posterior leaflet. And this is exact position which should be put on the second Pascal Ace. So we can grasp both this anterior posterior leaflet. So we start the procedure. This is a transcatheter puncture. So this is a very straightforward transcatheter puncture. I like to puncture the inferior posterior location because I don't like to the out-of-hugging trajectory. And we can see the 45 millimeter above the annulus. And this is first Pascal Ace. So I use also the live 3D MPR during the procedure. This is we insert the device in the closed position and open the device here. After capturing the anterior leaflet, we capture the posterior leaflet using independent grasping. After closing the clip, we worried about this movement of the posterior leaflet, so we apply the optimization. So we put the clasp again, and we optimize the posterior leaflet and drop the clasp. After closing the clip, as you can see, the moving of the posterior leaflet is much improved compared to the first clasping. So after closing the device, MR is still severe, but there is no MR around the device. Especially the important thing is to confirm the no MR jet, so medial to the first device. So as you can see, there is no MR, so medial to the first device, and also that we have to check the regular prolapse lateral to the first device. This is the actual target for the second device. So we release the first device and go to the second device. So this is the second Pascal ACE. So we control this device, so just lateral to the first device. So we confirm the perpendicularity and also the confirm the leaflet, both the anterior and posterior leaflet. So in this case, we capture the posterior leaflet using the diamond shape, and after capturing the posterior leaflet, we close the device a little bit and capture the anterior leaflet. After closing the device, so beautifully MR was beautifully disappeared. So this is the final result. So this is a trace MR. So we add the appendage closure device after that, and there is no MR, and pulmonary vein flow was much improved. So airway pressure, when we look at the airway pressure, we have the 45 to the 12 millimeter mercury. Actually, the procedure time only the 1.5 hours, despite the 2 devices and the 1 appendage closure device. So this is TTE. So this is a pre-procedure TTE, and the post-procedure TTE shows just a trace MR after 2 device deployment. So I think the Pascal device is a very, very helpful and useful for the non-central pathology. So this is also the P3 prolapse, and we capture the P3 prolapse. Try to capture P3 plus 11 to 5 o'clock trajectory, but this fast capturing, as you can see, that the device perpendicularity is almost 12 to 6 o'clock. So after closing the device, you can see some MR PISA from the medial to this device. So we elongate the device and change the perpendicularity to 11 to 5 o'clock and capture again. So after closing the device, there is no eccentric MR. So I think the elongation system is very useful to control such a narrow space. And also that we can insert the device in the elongated shape. So in this case, so I do the procedure with the P1 prolapse, and there is no height in here, so we insert the device during the elongation maneuver. So I elongate the device. So when we elongate the device, the tip of the device going to the LV, and after that I just advance a little bit, and when I look at the leaflet, so leaflet much fit to this device. When we confirm the leaflet insertion, we drop the grip clasp down at both sides. After the clasp down, we close the device, and there's no MR. So this is the initial data of the Pascal device for the non-central MR. Actually, this data was presented by Dr. Enta yesterday in the late-breaking clinical trial. And when we look at Pascal device number is very low. It's a non-central MR, 1.2. And also most of the cases that we use the Pascal ACE device for the non-central MR, and the MR is very stable. So in summary, so Pascal may be suitable for the non-central MR because the elongation maneuver can be used very easily and safely. So also the combination of the 3D MPR with the Pascal is useful for the procedure guidance of the mitral TEER in the non-central MR. Thank you for your attention.
Thank you very much, Shunsuke. You can come back and then we have a bit of discussion. We are approaching the end of the session, so let's take this opportunity to gather more experience because we've seen how efficient is the device in handling DMR in various anatomies, whether it be extensive jet, non-commissural jet, central ones, calcified anatomies, so a broad range of anatomies. We could witness that. So let's move a little bit more into the techniques and the technical aspects per se. And one issue that we have to discuss, you've demonstrated your more inferior and posterior puncture technique just to get rid of the aorta hugger. My question is, do you tailor your transeptal puncture height to the location of the jet, whether it be the medial commissure or the lateral commissure?
Thank you for the very great and difficult question for me. So I think the lateral commissure I think when we treat the lateral commissure, I recommend to avoid the inferior puncture because it's going to be a two opposite aorta hugger, so two posterior to anterior dive trajectory. So I always puncture the mid to superior and the posterior puncture in the lateral commissure. In the medial commissure, I recommend to puncture the mid or inferior puncture. But when we puncture the inferior, so height is a little bit low. So in our case, this case, so you can see the very enlarged left atrium. So I think inferior puncture can be done because the height from the annulus is very enough. But very small left atrium, I recommend to puncture just mid and posterior. But I think the Pascal device is very nice because when we puncture the superior for the superior side, so when we treat the medial commissure, sometimes the guide catheter going back to the right atrium. But in the Pascal device, once the guide catheter going back to the right atrium, we can do we can control the device using a steerable catheter, just a steerable catheter. So I think that in the Pascal device, we can puncture a much broad side of the fourth valves.
So thank you. That was a very detailed description of the various puncture site based on the anatomy that you are addressing. So it tells us that we need to have a tailored approach for every single patient. We can apply the same recipe for every single patient. And thank you for that very nice description. Tobias, you have a very large experience, and there is that new technique of elongation insertion for the commissural jets. Is it something that you do in your practice, or is it something that may be applied, that you're going to try?
No, I think we quite routinely use it for these kind of pathologies, and absolutely agree with your approach. I mean, you use the elongation feature here. Sometimes it's always important to, it's always important to really get the right trajectory in the left atrium. I think that's the key issue. To position right above the jet, to have a quite perpendicular angulation, and that's one key issue. And in your pathology, the elongation is very, very helpful. And also we would try to enter the ventricle with the elongation feature, and the diamond shape is also helpful in this location. Yeah.
KK, please. I have a comment, and I think Shunsuke demonstrated remarkably beautiful results. But I think the technology also facilitates and allows for very good visualization of the retention elements. I'm sorry, you tend to use the wrong words sometimes, but the retention elements very well visualized, and that is a powerful strength because you are confident that you have adequate leaflet grasping. I just wanted to commend the echocardiologist, but also perhaps the technology has that advantage.
And Shunsuke, you wanted to add on? Please, Fiores.
Yeah, I just want to comment real quick on the precision of the trajectory. I mean, almost all of the cases that we've seen, you've seen trajectory in the AP as well as the medial lateral is up and down. And I think that this is a combination of the ability to add flex to the guide, take the guide posterior, move the steerable catheter interior until you get the trajectory spot on. And you rarely see in any of those cases where you're coming aorta hugger. And I think even with the challenging transeptal height, those were able to be achieved by all of the operators, which I think is very important for success, especially in the commissures.
Yeah. So that's a very, very important point. One question for you, Sunchike. You emphasized the importance of MPR. Maybe not everyone is using MPR. We use it for more complex procedures. Is it something that you systematically do, or from time to time you stick to that explained view with the bicommissural, the LVOT projection?
Yes, so I think
You can jump on it.
Yeah, he likes 3D MPR
Yes,
pretty much.
3D MPR is a very powerful tool, and because you can see the 2D and 3D, and both image is important. So you can see the pad rotation and device position anterior or posterior. It is very important.
And I, even if it's not anymore the topic, thank you for the DMR, large gaps, large regurg. I wanted to ask you something, Makoto, about the high gradient and small mitral valve area patients in terms of management of these patients and the medication. You had a very high gradient prior to the procedure. Were you prone to increase the beta blocker in this patient prior to the procedure, just to make sure that you don't end up with a decrease in the quality of life, the symptoms, improvement of the symptoms of the patient, worsening of the symptoms of the patient?
Yes, thank you. Most of the patients do have atrial fibrillation, and they tend to have a beta blocker on the beforehand. But if the gradient goes up, and we would try to minimize the heart rate as possible. Also, we would see the patient's ADL, if she or he can, run around even if she's 80 years old, then we would try to minimize as much as possible, not try to make an MS. On the other hand, patients do have a very frail patient, then mean gradient of 8, 9 can be acceptable.
Is acceptable, okay. So very nice discussion as usual, but we need to move forward. So Kantaro, I guess it's...
Okay. Actually, this is our case, so maybe you can...
Okay, so you don't want to disclose the outcome, so let me ask Shingo to come back to the podium to give us the outcome for the patient, please. Thank you.
Thank you for your introduction. We would like to discuss about how we treated this case. This case exhibited significant regurgitation from indentations, along with a broad regurgitant jet primarily between A2 and P2. Additionally, regurgitation between A3 and P3 was observed as a secondary region. Although the P2 segment was narrow, we considered it feasible for device grasping. Based on these findings, we decided to treat this patient using the Pascal system. First, expecting the spacer to help control the surrounding indentation jets, we considered placing the Pascal P10 as the primary region between A2 and P2. If the residual medial jet was deemed unacceptable, we plan to treat the A3-P3 region using the Pascal ACE. Using multi-view, we adjusted the trajectory and rotation of the device, and first implanted the P10 device between A2 and P2. We confirmed that both leaflets were securely grasped. After the first grasp, a significant reaction in the lateral regurgitation was observed, and the residual jet was considered acceptable. Therefore, the device was implanted at the position. However, medial regurgitation remained almost unchanged. As initially planned, we decided to implant the Pascal A's between A3 and P3. The grasp of the PML was suboptimal because of interference with the P10. Therefore, we performed optimization to achieve a secure grasp of the PML and securely grasped it. The Pascal S was implanted at that position, and a reduction in MR to mild to moderate was confirmed. In the pulmonary venous flow wave, although the D wave remained dominant, the S wave also appeared, showing an improvement compared to the pre-operative condition. Sufficient MR reduction was achieved, and no significant mitral stenosis was observed. The patient was discharged without any complications. In this case, we could achieve sufficient reduction in by using the Pascal system for complex DMR. The Pascal system could be a better option for patients with degenerative MR. Thank you for your attention.
Thank you very much, Shingo. So there is, it's really almost the end, but let me ask you a couple of questions because I want to learn it all from you guys. Here we can discuss about the technique, Kentaro. Let me start with you. Usually when we use the other platform, available platform, we try not to mix the iterations. We try not to combine the iterations in order to avoid a distortion of the anatomy of the patient. Did you consider that with the Pascal? If you start with P10, is the right choice? Isn't it the right choice? The second device would be a P10, or is it frequent that you mix P10 and ACE, P10, and vice versa?
Based on my limited experience, I don't hesitate the combination of the different devices. And we usually start from P10 as far as possible because they will leave the MB a little bit larger. And then so we additionally put the ACE. It's much better for the non-central lesion. But I am very much careful to adjust the clocking direction of the device because otherwise it'll be quite difficult to clasp the second one.
Maybe briefly from you guys, same way. Are you reluctant to combine, or is it something that you do regularly?
I think it's an option to combine Pascal P10 and Pascal ACE because leaflet insertion is similar between both devices. I don't think that we change the geometry so much in comparison. For example, using a XT, W, and NT, for example, I think that's a different situation. And then, of course, it's about the shape of the devices, which is a bit bowly, or with a Pascal P10, and it's easier to get closer with the second device to the Pascal P10 than with another Pascal P10, I think. So this.
Yeah, I agree, and I think the 9-0 frame of the device also help because you're only going to exert certain amount of tension, and I mixed P10 and ACE quite a bit and never had issues with it.
Okay. So I think we need to close the session. It was a fantastic symposium. Once again, fantastic session. What did we learn today? So did we learn a lot about the patient selection for DMR treatment with the Pascal? I would say no, because what we learned is that in fact you can treat any type of DMR. We have treated extremely small mitral area, and then with an excellent outcomes. We've treated extremely complex DMR. It's all about getting used to the technology, understanding how it works, how you can combine the iterations, how you may adjust your techniques, whether it be the transeptal height, how you're going to engage the anatomy. It's all about all these tips and tricks that we have shared with you, and it's very important to understand how it works and how you're going to integrate it within your practice. We also learned that the results that you observe per procedural before the release are going to be maintained in terms of residual MR and gradient that you're going to observe, and are going to certainly be sustained up to 2 years and certainly beyond that, based on the data from the randomized trial and the registry that we've shown all together. We've seen all together. So having said that, I took a lot of fun being part of that session because I learned a lot with you guys. Thank you for sharing your expertise, your experience. Thank you, Kentaro, for moderating the session with me, and thank you to Edwards for housing such an educational session. Thank you.